And I'd like to start with thanking the organizers for inviting me to this great meeting. These are my disclosures. And before I take off, this is obviously very clear to all of you that atrial fibrillation is the most common arrhythmia, affects a large proportion of the population, and is associated with an increased risk of stroke, heart failure, dementia, and death, let alone the other symptoms that patients with atrial fibrillation may experience. There is a strong relation between the onset of atrial fibrillation and the activity of the autonomic nervous system, and that has fueled the idea that maybe we should modulate the autonomic nervous system to improve our ablation or medical strategies. The autonomic nervous system in the heart, and particularly in the atrium, resides in the ganglion plexus, and the ganglion plexus are relay stations. There are 4 or 5 of them that are sitting in the epicardial fat pads of the heart or on the left atrium. Aside from that, the epicardial adipose tissue, or EAT, in itself has been shown to elicit profibrotic properties to the heart, and if you subject heart cells to the secretome of epicardial adipose tissue, you promote the formation of fibrosis. So I'd like to focus on 2 questions in this presentation. One, can we ablate the epicardial nerves and have a better procedural outcome? And 2, can we identify substances in the secretome of the EAT that affect atrial remodeling and AF? I'd like to take you to some studies done by the Oklahoma group, and I got the slides from Sonny Jackman, for which I'm very grateful. And they showed how activation of the autonomous nervous system contributes to the onset, to the initiation of atrial fibrillation. What they did, they used a dog model where they impaled the atrium and the pulmonary vein myocardium and recorded action potentials, and then they provided high frequency stimulation to the nerves. And what they showed was that if you do that, you get some capture and you get some ectopic activity, but most importantly, preceding that, you get shortening of the action potential. So if you provide high frequency stimulation, you get shortening of the action potential and ectopic activity. If you now apply atropine that blocks the parasympathetic arm of the autonomic nervous system, the shortening of the action potential is absent and the ectopic activity is absent as well. And if you wash out the atropine, this mechanism restores. So at least this is dependent on the parasympathetic arm of the autonomic system. If you do the same experiment by applying high frequency stimulation and now applying atenolol, a beta blocker, you see that you do not abolish the shortening of the action potential, but you do abolish the ectopic activity, the firing from the pulmonary veins. And as a final intervention, the investigators applied ryanodine, that again did not abolish the shortening of the action potential, but did abolish the triggered firing from the pulmonary veins. And with the 3 observations, the authors concluded that EADs and triggered firing are dependent on calcium release from the sarcoplasmatic reticulum. That is because it's blocked by ryanodine, and it's also blocked by the beta blocker, but that for the action potential shortening to allow this triggered activity, parasympathetic innervation is necessary. So a logical step would be, if this is bad, let's burn it out. So let's see if we can ablate the ganglionated plexi. And there was this randomized trial by Katrixis et al. 10 years ago that showed that if you do that in combination with pulmonary vein isolation, that you end up with a better outcome of your procedure. There are some caveats on that study. One of the caveats is that the amount of RF in the group that combined the PVI with the GP ablation was approximately 50% more than in either of the two groups alone. Also, that ablation of the GPs in itself did not show this effect. However, it was a safe study. There were no adverse events noted that were unexpected. One of the explanations for their finding, however, may be that if you approach the epicardially located nerves from an endocardial side, you have to pass the myocardium. So one of the hypotheses of this finding is that it's just a better PVI, it's more myocardial ablation, and that may have caused the effect. And that is why we designed the AFAC trial, where we used a thoracoscopic approach, an epicardial approach, to ablate the ganglionated plexi. So we had 318 patients screened, of whom we randomized 240 to thoracoscopic ablation with PVI. In case of persistent atrial fibrillation, also a roof line and a line to the trigone, to the left fibrous trigone, plus or minus ablation of the GPs or ablation of the fat pads. And these patients, some of them were lost to follow-up. They were followed for 1 year, and the baseline characteristics, they were 60 years old. Approximately 2/3 of them were male. They had advanced atrial fibrillation with 60% persistent, usually enlarged left atria, failed catheter ablations, etc. So they were not first comers. BMI was 27. Left atrium was enlarged or severely enlarged in 70%. 23% had the previous catheter ablation. The CHEST-VASc score was more than 2 and 40%, and they were all on anticoagulation at the start of the procedure. And 99% of them was on antiarrhythmic drugs. The effect was somewhat disappointing. There was no effect whatsoever in the freedom of AF after 1 year. There was no difference between, this is the 2-year data, but as you can see, at 1 year there's no difference either. There was neither a difference in paroxysmal AF or persistent AF. But there were differences in the adverse events of the procedure. Most notably, there was more bleeding in the GP group, but also more sinus node dysfunction and more pacemaker implantation. So there is a harm side and there's no benefit of the ablation of the GP. So we have to think again about how the epicardial adipose tissue affects the substrate of AF. We've previously shown that the interstitial fibrosis is a substrate for atrial fibrillation, and that's of course not new. But what was new is that we found that there's a difference between the organization. If you have this thick strands of fibrosis in the atrium, that can form lines of conduction block that can anchor reentry. And this was independent of the percentage of fibrosis, but was dependent on the organization of fibrosis. So we continued thinking about how this EAT may affect arrhythmias, and what we did is we investigated the secretome of the EAT that was derived from patients undergoing thoracoscopic ablation, so from patients with atrial fibrillation, and we subjected neonatal red ventricular myocyte cultures to this secretome. And Oriane Ernaud published this, and she showed, I will not go through this figure because it's a very busy figure, but we used the adipose tissue, we collected the secretome, and we incubated for 72 hours cultured cells with the secretome of AF patients. And if you now look at the difference between subcutaneous fat, control medium, or epicardial fat, you see that there's marked conduction slowing by the secretome of EAT of AF patients. Next, we thought let's have a look what kind of proteins are actually present in this secretome. And one of the proteins that stood out, this volcano plot shows all the proteins that are less expressed in atrial fibrillation compared to control, and that are more impressed, and this is the fold change here. And MPO, myeloperoxidase, stood out as one of the candidates and one of the most important proteins that is excreted by the epicardial adipose tissue. And if we specifically look at MPO, and we look at how MPO affect fibroblasts, and fibroblasts are the cell types that actually make the fibrosis, that actually cause the deposition of extracellular matrix protein, we see that the secretome here causes fibrosis, collagen expression, and fibronectin expression in if you use the secretome from EAT patients of AF patients versus that of non-AF patients. So not only is the origin of the EAT important. I showed you in the previous slide that there's a difference between subcutaneous fat secretome and epicardial secretome. Also, the secretome from AF patients is different from that from non-AF patients, and we showed that this coincides with MPO and with NETs. NETs are neutrophil extracellular traps that are the products of neutrophils, and neutrophils are the most important cells that excrete MPO. And indeed, we found that NETs were more present in patients with persistent atrial fibrillation than in patients without atrial fibrillation or with paroxysmal atrial fibrillation. But interestingly, we also found using the secretome and the histology of the data of patients that we followed that did not have AF but did undergo cardiothoracic surgery, we followed them for the onset of AF for 2 years, that those who would develop AF already had more NETs production in the heart than those without AF or those with paroxysmal AF. And indeed, if you look at the histology, you see that the EAT in patients with persistent AF is markedly stained for MPO, that is absent in patients with non-AF, who do not have AF, but that there's already MPO present in patients who will develop AF later in life. And this is relevant because this EAT, this inflamed EAT, this EAT with MPO invades the myocardium and forms fibrosis and strands of fibrosis that I previously showed you to be pro-arrhythmogenic. Again, in the total EAT, persistent AF shows more MPO than does paroxysmal AF, non-AF, or the patients who will develop AF later. And this also accounts for the subepicardial MPO, but not for the MPO present in the mid-myocardium. So this brings me to my conclusions. There is a role of the autonomic nervous system in AF initiation, and I showed you the data from the Oklahoma group that clearly show that if you stimulate the autonomic nervous system, that you can induce the triggers for AF, which is something that can be ablated. However, there has been shown some beneficial effect of GP ablation on top of PVI in patients with paroxysmal AF, but if you look in more advanced AF in the prospective randomized APEC trial, there was no benefit of RF ablation of the GPs, with no difference in outcome after a single procedure at 1 year, and there were no subgroups with benefit from GP ablation identified. The epicardial adipose tissue in which the ANS resides is metabolically active, and its secretome is pro-arrhythmogenic because of slowing of conduction in isolated cells. And it may be central as well in the formation of interstitial fibrosis, which is driven by neutrophil activation and the production of myeloperoxidase. But obviously, future studies are needed to understand whether we can modify these processes and by that affect the outcome of our procedures or even cure AF if we're very optimistic. I thank you for your attention.